the Neisinger Child Behavior Rating Form, and they had more aggressive behaviors on that than patients did with Prader-Willi or Fragile X syndrome. And this next slide will show that. Again, significant to less than 0.001 level. So as far as treatment for Smith-Magenis related aggression, treating the hyperactivity with stimulants unfortunately is not very effective. And as they have a high rate of seizure disorders, as was pointed out earlier, and even abnormal EEGs without overt seizure activity, a better first choice would probably be an anti-epileptic drug, again with low weight gain potential, perhaps carbamazepine to start out with. Another option would be an SSRI, especially if we think that there might be obsessive type anxiety, which is also a little higher in this group than it is in the general population. And even though a risperidone can reduce aggression, the atypical antipsychotics should probably be avoided, or if they're going to be used, monitored extremely closely, because the Smith-Magenis syndrome patients, about half of them will have hyperlipidemia. Other alternative medications to consider would be lithium, especially if their EEGs are normal, and beta blockers. Tuberous sclerosis complex is indeed complex because of the high rate of seizure disorders, lots of ADHD, but also physical things such as cardiac and renal problems. Aggression is very common in this group and varies widely in severity, and unfortunately does not tend to get over with time. In other words, the kids don't outgrow it, except for the destruction. That tends to get better, but physical aggression towards people tends to stay fairly stable. Here is this next slide by DeVries et al. Showing behavioral, psychological, and psychiatric problems in kids with tuberous sclerosis complex. And aggressive outbursts, you can see that the overall group with mental retardation and without mental retardation, there was no statistical difference. In other words, it's not about their intellectual impairment, it's something about the syndrome itself. And when we look at the physical features in this study, they found that 92% overall had seizure disorder, epilepsy. However, there was a significant correlation between the presence of mental retardation with much more likely to have epilepsy if they had MR also. As far as treatment in tuberous sclerosis, as far as the aggression goes, much of the aggressive behavior is probably related to the seizure activity, so we need to maximize the anti-epileptic drug. However, it does tend to respond poorly to those medications, the epilepsy, and there's lots written about the management of epilepsy in this group. Psychiatric comorbidity is also common, so we'd want to identify and treat, and hopefully that would decrease the aggressive behaviors. This next slide shows symptom group overlap and also treatment histories and referral for psychiatric treatment in the TSC group compared to those that also had mood disorders, anxiety disorders, and ADHD. So for those that had aggressive disruptive, there was a lot of overlap with mood disorder, about 44%, overlap about 30% with anxiety disorders, and 45% with ADHD. What's also interesting is that those that had a history of psychiatric medication use represented 54% of the aggressive sample, and also those that had been seen by either of two psychiatrists that were affiliated with the study, about 38% that had aggression. So there's a high rate of intervention and need in this population and some complexities in their treatment. So risperidone has shown efficacy in reducing some of the problematic behaviors, including aggression. We also have to be careful because anything that can affect cardiac conduction should be delayed until they've had a good cardiac workup. And the reason is because half of them will have cardiac rhabdomyoma, a tumor of one of the chambers of the heart, and about 20% of those will be associated with arrhythmias. And again, we don't want to do bad things while we're trying to do good things to help these patients. The next syndrome is Cri-du-Chat, and there's speculation that a lot of the aggression that occurs in this syndrome comes from the poor communication skills that they have, again, possibly related to frustration. Hyperactivity has also been variously reported, and fortunately that does seem to go down with age. Cornish looked at the Vineland adaptive behavioral scales to see what proportion showed various different kinds of externalizing behavior. And those that were described as being too physically aggressive in the Cri-du-Chat syndrome population that they looked at was about 30%. Collins also looked at this question about aggression and destruction in children and adults with Cri-du-Chat syndrome, and they also found that there was a fair amount of occurrence with this next slide that you'll see about 65% evidence hitting others with their hand or another body part, 65% pulled hair, and the lowest rate was about 36.4% with either hitting others with objects and scratching others. So again, at least a full third will have some kind of fairly significant aggressive behavior. As far as treatment, it would be more behavioral and speech language, and if that didn't seem to help, then a cautious trial of stimulants because of a high rate of ADHD in this population. Autistic spectrum disorders we know are very, very common, and that will be commented on later on by some of the other presenters. But prevalence of concurrent disorders is very high. And we can see here in this next slide that aggression was about a third, 32%, with aggressive behavior in the autistic spectrum. Because we were talking a lot about medications today, one study that showed that about 78% of the aggressive patients with the autistic spectrum had mood disorders that were not recognized. And recommendations, rather than to add or increase atypical antipsychotics, was to maximize treatment with mood disorders rather than antidepressants or mood stabilizers. Now, part of the problem with this study is that it was very small n, and they lumped things like adjustment disorder and schizophrenia into mood disorders. And when we actually look at mood disorders proper, it was still about 56%. So it's still a significant percentage that have aggression and unrecognized mood disorders. And I think that the recommendation to start with mood stabilizers first is probably a pretty good one. However, in the absence of a mood disorder, our good friend risperidone, again, is the agent of choice for aggression in children with autistic disorder, and much more will be commented on by other speakers in this series. Smaller studies have also shown other antipsychotics such as ziprasidone and aripiprazole can reduce aggressive symptoms. Olanzapine, interesting, was ineffective, and quetiapine actually increased aggression. Another review of the English language literature that included 21 RCTs and represented 12 different medications, one of which is not available here in this country, tianeptine, but methylphenidate, risperidone, clonidine, and naltrexone all demonstrated improvement of aggression versus placebo. And risperidone and methylphenidate trials have been replicated in at least 2 studies, so the best data is with risperidone and methylphenidate. One group reported on a novel approach to the treatment of disruptive behaviors in autism, and that was the acetylcholinesterase inhibitor galantamine, which is used for dementia. Even though we need further study, it did produce significant reductions in the aggressive behavior. So something to look at in better research down the road. Mattson and Dempsey did a really nice review article on autistic spectrum disorders and pharmacotherapy. And they really recommended a cautious approach in using medications in this group. And I'm going to quote here. They stated that before using medications, quote, problems should be chronic, severe, and unresponsive to psychological and educationally based treatments. Even in these instances, combined treatments of ABA, meaning applied behavioral analysis, behavior therapy, and medication would seem to be prudent. And what is reflected in the literature is a far cry from this priority set, unquote. What they really are commenting on is that we tend to use medications fairly quickly, fairly liberally, without a lot of data behind it. The next syndrome, Down syndrome, we think of them as being very loving, very happy, but about 10% can present as oppositional and aggressive. And also, given that ADHD is present at rates similar to control groups, and anxiety, depression, and seizures increase in incidence and with increasing age, it's not surprising